60-year-old Hispanic woman with a family history negative for GI neoplasms. She is a smoker, she consumes 1 alcohol unit per day, does not have diabetes, and had a 3-kilogram weight loss in the last 5 months. In 2006, she was diagnosed with an autoimmune hypothyroidism, treated with replacement therapy. In 2006, Sjogren's syndrome, treated with methotrexate and Plaquenil. And in 2012, a hysterectomy for uterine carcinoma was performed. The patient was under follow-up, and during follow-up, an abdominal CT scan showed a 39 millimeter focal nodular lesion of the proximal duodenal wall with irregular pattern. The lesion was highly vascularized with contrast enhancement and with calcifications. The blood tests were normal.
We just took an unusual upper gastroscope, which is EG2990I from Pentax. So it's a very nice scope, a slim scope, and you already see the lesion. So we are at the level of the second duodenum, and you see that the lesion is quite smooth in appearance, but it's a bit, let's say, a bit bluish. Probably it's vascular, and we already know that from the CT scan. But the surface looks very smooth, so we discussed already, and it looks like a benign lesion. Nevertheless, we would like to characterize a bit more the lesion. So here it's not very clear.
Why not playing a little bit with the lesion?
We can play a little bit, but I think it's soft. We can take a biopsy forceps, keep it close, and play a little bit to see how soft it is. So
the audience, what would be the impression of such a lesion? So we had a nice lesion in the last weeks, which looked similar and finally proved to be only inflammatory fibrous tissue. Do you believe this is neoplastic, or do you believe this is, how to say, something reactive? We really wonder about your advice.
I could imagine the vascularization, the superficial vascularization could be in concordance with the paraganglioma and the depressed center. How does the crater also feel soft? That would be interesting.
So we were going to play. We have been asking for a forceps to play a little bit with that nice lesion.
And before that, I don't want to cause any minor bleeding, but you see that we are already playing with the endoscope. I have a bit of funny position, but anyway, I'm trying to look into the camera. So we can play with the surface enhancement and with also with the vascular pattern. So now we just switch to iScan, and just at a press of a button we can switch to different modes. So now you see on iScan maybe a bit better the vasculature, and then if we press one more time, that's the normal mode, and I'm trying to enhance a bit the pattern, let's say the mucosal pattern. So now it's a bit, maybe it's a bit more clear. I'm not sure if it's visible in the audience, but we can play a bit with the mucosal pattern, which looks pretty normal. Nevertheless, if we change to iScan, then you see it's really vascular.
What could you ask the audience? Who would take it out, or who would, how to say, go for more indirect diagnostic imaging? So I really wonder who would be the people who take it out in the percentage.
What do you mean, Christoph, what do you mean by indirect diagnosis? You need an histology. I think it looks ugly. This depressed center and this vascularization looks uncomfortable, and one should obtain an histology.
Yeah, that's true.
And it's probably too big. We know from the CT scan that it's almost 40 millimeters. So it's probably, this is only the tip, and the lesion is probably much bigger.
I totally agree that we need histology.
Keep it close. No, keep it
but
close.
It could be done by removing the whole lesion, or it could be done, how to say, step by step.
So you see that here is quite soft on this part, but on the other hand, here it's a bit more, let's say, rigid. So you see that it's moving. I can move all of it. Yeah, it's quite stiff in the let's say the margins in the depressed part, but here is quite soft. So I wonder if there is probably some normal mucosa here, and then in the depressed part it's probably the tip of the lesion.
I think the true size, Christoph, the size, the true size is not so large as it looks. I think it looks pseudo large for the peristaltic pulling of the peristalsis. I would remove the center.
Okay, but yeah.
Could be. What also what looks similar sometimes is can be metastasis of
renal cell carcinoma.
They look
Yeah.
similar.
So it's also the typical location. But if we look a little bit deeper, it seems to much larger than
Yeah.
we assume. So this seems really to be the
It's
tip
only
of
the
the
tip,
lesion.
yeah.
So we'll go for the endoscopic ultrasound right now, I guess.
We'll change it.
Yeah.
Thanks.
Yeah, we change and we'll change also to the other room for this
Thank
moment.
you very much.
Okay, this is a good decision.
We will be
We need to do some contrast also.
very nice.
Elastography. It looks very. So we just changed the scope, and now we have a linear scope. We discussed already, most of us prefer the linear scope. Of course, we could do this with a radial scope, but we just took a therapeutic, a standard endoscope from Pentax, so it's the 3870 UTK. It could have been done also with a slim scope, but we decided we want the standard scope because it's a little bit more stable in the duodenum. And we inflated a little bit the balloon just to keep the position steady. And you see how the lesion, so Christoph is doing a great job. It's a big lesion actually. So what we have seen in the duodenum was only the tip of the iceberg. And you see it's pretty big. Now you can see it with elastography. So it has different portions. Probably it has some necrosis inside. But most of it is really blue or let's say a low stiffness lesion. And you can easily characterize this also with color Doppler. And actually what you see now, I have to hold the scope, but could you please show the vessels on the right side? So actually what you see is the big vessels that we have seen. So that's where the duodenum is. I'll try to keep the scope steady. So without artifacts, that's where the duodenum is. So you see some large vessels. So I don't think this should have been in any way resected by endoscopy. So the only thing that we would have resected would be the large vessels. So this might have caused major bleeding. So this is one of the advantages and nice things about EUROEUS, because you can really characterize the vessels, which are really dilated here in the periphery. There are also central vessels, there are calcifications, there are some small cystic masses inside the lesion. So there are a lot of criteria of probable malignancy. Also the size is pretty big.
If you look for the tortuous vessels right on here, where perhaps you can go back to this one, it's a tortuous and the capsular penetrating vessel right on here. And if you look over there, you can see also penetrating vessels. So it's not such an umbilicus, well differentiated vessels. You can see from the vessel architecture that this lesion at least behaves semi-malignant, I would say in that way. And we decided to do some contrast.
It's probably if we no,
sure.
just a little bit, just to change the just a little bit. So we need to go to the contrast specific mode. And I'll try to keep the lesion steady. It's a bit unstable because of peristalsis. It's the opposite left right, but it doesn't really matter. So I think we are.
So we are almost ready.
Almost
That's
ready.
a very nice image. We increase the acoustic power and we're ready to go.
Yeah.
You go?
Yes. Yeah.
Okay.
Start, and I'll press the timer.
Okay.
So now you see that it started the contrast starts to go from the periphery to the central part. So,
which is also how
now,
to say.
Now you see it better. So it was really fast in the arterial phase, and now you can play. I think Christophe can play also with the flash. We can give some flashes, and you'll see it enhancing again. So it's really highly vascular. I would say it looks like a GIST lesion, most probably, or another.
The location is against GIST, and in such a large lesion, I would, I would expect also some ulcerations at the top, next to the mucosa. So. But you might have a very good idea with the ganglioneuroma. So that could be any sort of subepithelial lesion. Yeah.
Yeah, I agree.
What did I do wrong?
There is some calcification in the center of the lesion.
Yes, in such a large lesion, it's typical. Yeah.
Unless they're treated with imatinib, and more like a neurogenic tumor, perhaps a GANT.
If in a GIST tumor, even with a size of 2 centimeters, I would expect necrotic areas. And in a lesion of 3 and 4 centimeters, it would be, how to say, a typical sign of GIST. Therefore, my personal, a guess is not GIST in this case, because in GIST, in such a huge GIST, I would suspect, due to our results in about 30 GISTs which we have been examined by contrast, I would expect typical spontaneous necrotic zones, except calcifications. So we would suggest any other subepithelial, lesion. It's a clear indication for surgery, and there is no need for any kind of biopsy. Only if we are forced to do it, we will do it. But there's no need. It has to be taken out. Yeah. And we will see afterwards it is neurinoma, schwannoma, ganglioneuroma, whatever.
How is
actually
the anatomic relation to the papilla?
It's far away.
It's far away, and it's distally.
Yeah. And it's on the other
here's
wall.
the papilla, and it's down here.
Okay.
It's distal, and it's a big lesion, and most of the GISTs have an undeterminate risk of malignancy. But due to the size and due to all the characteristics that we have seen already, calcifications, vascular, highly vascular tumor, I think it should be taken out. It's probably borderline malignant or even more than that. But it should be characterized by pathology, and we need the whole tumor analyzed by pathology.
To our understanding, there is no history of renal cell carcinoma, but we should be aware that 10, 15, 20 years metachronic such lesions would appear. But the lesion of the renal cell carcinoma, to our understanding, would be, even more hypervascular than this lesion. So from the morphological point of view, it's not such typical. But we will go for the past medical history in that regard. To our knowledge, no. So any comments from the audience? Proposals?
Yes, we want to have the resection result on the homepage
come here.
of
There's the real joke. Okay. Our pathologist suggested biopsy.
No, fine needle aspiration also. You have probably an immediate answer.
But it wouldn't change our opinion. If it's benign, it could be malignant at a different location of the lesion. If it's malignant, we take it out, so there's no doubt. From a patient point of view, we should avoid anything which is harming. Neil Notzerer.
But probably the approach of the surgeon could be different.
Agree completely.
If he knows the answer before. Yes, that's